Devin, let me kick it off with a question to you. It's just a conundrum that bothers me, and I'm sure you've thought about this a lot, but I'm going to start with a presumption that most health outcomes are determined by social determinants, not what happens in the 0.5% of the time when you're in a clinic or a hospital. And then the next part of the logic trail is, in my other life, I have access, I meaning a corporation has access to almost everything about you. What you buy, what you are interested in, where you go, how fast you walk, you name it. Now, I will say, as a loyal employee of a company, I went through the rigorous training, and the ethical principles are substantial, and the penalties internally for violating them are severe. But the fact is, Congress even passed a law just recently that made it even easier for companies to deal with you on the internet to use your data for all sorts of purposes. But then we got this and that's most of what determines how long you live and how functional you are. Then we got this little sliver that happens in hospitals and clinics, and we treat it entirely differently. Why is that? Do you understand it, and does it make sense?
Well, I'm not going to disagree with you at all that it doesn't make sense in terms of a way to order the world. It just happens to be not the way we typically, at least in this country, regulate data use. We have a very sectoral approach to doing this. So we, aimed our privacy and security regulations at hospitals and doctors and health plans because at the time we were trying to facilitate electronic claims transactions. And somebody said, oh, we're going to be digitizing some pretty sensitive data, so we probably need some privacy protections for that. And that generated HIPAA with its sort of very specific regulatory circle. You're either covered by HIPAA or you're not. And when you're not, you don't have to worry about those rules. We have the Federal Trade Commission's authority that extends to commercial companies like the one that you work for, but their sort of sets of expectations, while not entirely dissimilar from those under HIPAA, are not as spelled out in detail. They expect you to be fair and not deceptive. And the expectations around use of data in research in a context of submitting information for regulatory approval or under the common rule, again, all sort of emanate from Belmont principles, but again are sort of focused on through the lens in which they need to sort of operate within their authority. So certainly it isn't a logical way to order this. If the bottom line outcome that you want is trust in these uses of data, then the fact that we sort of apply these rules, say what you will about the content, the patchwork application of them does create this sort of discontinuity, right? I think far better for us to come up with some consensus principles for moving forward. And I do agree with you, there are a number of companies who sort of recognize the value in proceeding in an ethical way in this, and also to the potential consequences from a business reputation standpoint of not necessarily protecting the data that they're collecting. But I think it goes to the issue of trust about whether there's whether just sort of voluntary commitments is necessarily enough. I don't know if that really answers your question, but that's my view on it.
I think it was a thoughtful response, and I wasn't seeking a clear answer because I don't think there is one. One other just quick observation to think about, and then we'll get to the 50 minutes we have left for the discussion. Scott Ziegler pointed this out to me at a meeting a couple of months ago, and I still haven't gotten over it, but about the asymmetry in the context of what we're talking about today. If I want to encourage you to have an unhealthy behavior, that's called advertising, and I'm totally free to use everything I know about you to influence you, even using randomization, which is commonly done, randomizing different ways to influence your behavior because you've ticked a box at the beginning of the signing on to Amazon or Google or whatever you did. I'm totally free to do that. If I want to improve your health, then it comes under a whole different regime, which is almost impossible in most cases to do unless you're really an expert. So anyway, you don't need to respond to that, but I still haven't figured out what to make of it. So, Greg?
Yeah. I had first a shameless plug and then a provocation. The shameless plug is that some of us involved in the collaboratory do have a paper coming out in Annals within the next few weeks about sort of data sharing and concerns from health systems and the whole issue of health system privacy. So, because that's another aspect we haven't talked about as much. But main point I wanted to make, I wanted to come back to sort of, Rory's, sort of bold and provocative statement that he hasn't done GCP training. And made me imagine sort of a 12-step style GCP anonymous meeting where I would stand up and I would say, my name is Greg and I've done GCP training, but I haven't used it in 37 days. And everybody would say, 1 day at a time, Greg. And the analogy that came to mind as Rory was talking about that is as if, you were, heading back home and you arrived at the airport and they told you, because of many improvements that we have made in airplanes, they're now too heavy to take off. So we've rebooked you on the train. Good luck with that.
My name is John Birch. I'm an angel investor with the Mid-America Angels in Kansas City. And I have a question primarily, I think, for Devin, actually, but it relates to pharma's use of real-world data and regulatory use of real-world data as well. I noticed a few years ago when the learning health system concept was just being widely discussed that with the development of smartphones, a black market in learning health system was already developing. And what I mean by that is medical students who always had their little smartphones with them, were constantly comparing notes with one another. Did this work for you? I tried this with my patient. Did it work with you? This kind of thing. They were just learning from one another already. In other words, that technology drives, it creates the opportunity and the reality of a learning health system. Whether it's good or bad is another question, perhaps. And some people approached me because they were very concerned about that. But my question here is, the same kind of channels are already developing in real-world data. There are today, by my estimation, 500 to 600 personal health record companies, comparable to what Google Health tried and Microsoft Health 10 or more years ago. They're mostly app-based, some web-based. And they're all, and I hear these entrepreneurial pitches all the time, they're all saying, well, we have some sort of an application, like a community, a patients like me kind of thing on the small. That's the value that we provide to the patients, and so we aggregate their data from this and the other EHR that they go to, and that's the value, but the real value is in the data. And we, the entrepreneur, is going to sell the data because it's not protected. And because they have used HIPAA basically on behalf of the patient they've invoked HIPAA on behalf of the patient to collect their data in a repository under the patient's name, then they possess it and de-identified, they can sell the data. Or can they? I guess that, of course, begins to get into the question. So there's a whole new world developing here in this kind of data that I really think is important to understand. And as an investor and a mentor to entrepreneurs in this space, it's very important to understand. But basically my question to you is this. When patients do collect their data, it is suddenly no longer protected health information. And they're free to do whatever they want to do with it. And in many cases, just as Rob was saying, some unscrupulous person can come up and entice their data out of them and use it for all kinds of purposes. So it's essentially an end run around HIPAA. HIPAA allows it, oddly enough. So I guess I just throw that out as a question, but it relates to pharma's possible use of data that might come from these sources. So there's no provenance, or sometimes there might be. There's no control over it. Some of it might appear as registries, which are totally unregulated. essentially, as far as I know, there's a whole lot of registries. Let's just put it that way.
You should respond to
So,
just to point out about the registries. I think you're saying in a case where patients band together without a healthcare provider involved, and it's not regulated, right?
Yeah, the provider-based registries are absolutely covered under HIPAA. Because it's the providers who share and send data to registries, use data in registries. Those would be HIPAA covered. But you're right. I mean, again, given the limitations that we just discussed, that Congress created HIPAA for a particular purpose, and it wasn't for health data privacy. It was to achieve other policy goals, and it just so happened that they realized that they needed digital data protections for digital claims adjudication, and so hence it has limited applicability. When there is in HIPAA, as I alluded to in my talk, there are only two rationales for which an entity covered by HIPAA is required to share data, and one is when the patient requests it and asks for it to be sent to a third-party designee on their behalf. That is a must-do, except in very rare circumstances, and then to the regulator, of course, when we're investigating. So that means it is the case that in the commercial space that is uncovered, if they are obtaining data on the patient's behalf and with the patient's authorization, what then happens to that data is not subject to HIPAA protections, but is instead subject to enforcement of commitments made to those consumers by the companies. That's the FTC's authority around unfair and deceptive trade practices. That it triggers all the bigger policy questions that we've just discussed about whether that's a good idea or a bad idea, and but it is what it is. And just to answer your question, you're absolutely right. I don't call it an end run around HIPAA necessarily. I'm not sure that the way that the pace at which patients are accessing their data today means that it is a substitute for institutions at the healthcare provider level, participating more in real-world evidence generation, because they're still going to be trusted sources of that data. But I do think it's only a matter of time from a scale perspective about where the sort of consumer-facing space goes and the kind of data that's going to be in that space and potentially available. It's going to be expanding rapidly.
Just the final comment is for pharma and regulators need to be aware of this as well, because a lot of the data that comes to you as real-world data might come from suspect sources.
Yeah, I think we would be at least for the FDA, would be very aware of that. We would look at the sources. We would understand that. So we don't just accept random data sets that are sent in to us. So, and, the issue right now is that there's looking at observational data with a fairly jaundiced eye at the regulators. So I think that's low risk because we verify everything.
Reserve time, we'll go to the group here for two exercises by our panel members. The one at the end of the time, if each of you could be thinking about, if a two-part question, do you think we're moving fast enough into the use of real-world evidence? And if the answer to that is we're not moving fast enough, what are the three things that you would do concretely to move it along? The other exercises I'd like you to divide into pairs. Patrick and John discuss the issue of what does all by all really mean to people that are doing traditional pharmacoepidemiology with all the p-hacking and all that other stuff. And then Rory and Janet to discuss what should be done with GCP and what that means. But let's hold that in reserve because we have audience comments and questions.
Yeah, I wanted to, actually along those lines, I wanted to come back to, the really wonderful presentation Patrick gave about this all by all. And to me, one of the things it revealed, I'm always interested in sort of solving a problem by turning it on its head. Because we heard about this sort of data misadventuring or p-hacking, the selective reporting, which may sometimes be conscious, but most times is well-intentioned and unconscious. But people still do that. And instead of saying, well, we need to vet this, and only some comparisons are allowed to get through, what you do is turn that on its head and say, no, actually, all comparisons are required. So instead of saying only some are allowed, we say everyone is required, which is an interesting upside-down way to think about that. But it gets me back to one of the questions I started the day with, suggested by Scott Gottlieb, about this data, about this curation question. If we are to become curators, what is the right curation model? And the sort of disturbing thing I thought of as you were showing those pictures is that human curation of the truth is, despite our best intentions and all of our best efforts, inherently corrupt. That if elites curate, that the curation will inevitably be biased. So just curious about your thoughts. How do we get around that? Do we just say there is no curation at all and it's all by all?
Thanks, Craig. So an important component of the idea that we should allow for an expansive set of analyses to all be openly and transparent and consistently made accessible is the idea that each study result, so each one by one, is not just a piece of evidence, but it's a piece of evidence that's accompanied by an evaluation of how trustworthy that piece of evidence is. That is, we're not just getting a relative risk, we're giving ourselves an assessment of should you believe this relative risk. And we do that currently in current epidemiologic practice. We do that through sensitivity analysis and some limited scope diagnostics. However, we have too many examples, like Rory pointed out, where we've got examples where despite our best efforts, we think we might not have gotten the right answer. The suggestion that the Odyssey community we've been focused on is the idea that maybe there's something that goes beyond the within study diagnostic to tell you if you should trust a given answer. And in this particular case, the population of studies, in fact, gives you a level of trustworthiness that, or it gives you an assessment of whether or not you can trust information. So the idea that you look across multiple databases simultaneously, that means that instead of having one study conflict with another, wait another year for another study, and then you do a meta-analysis 10 years later to say that we don't know, you're getting those 6 or 10 answers instantaneously. You make your own assessment of whether the preponderance of the evidence makes sense. Similarly, you can actually think about the totality of the Bradford Hill causality criteria. Rory made a very clear point. If we had clinical trials for everything, we would just be done. We wouldn't need observational studies. We also know that observational studies aren't going to be perfect, but what we need to be able to do is, given that observational studies can provide some information, yet they still might be fallible, how can we use that information to know how much we can rely on it? And I think that part of this flipping the model upside down is another attempt to try to provide us that information. It does, though, mean that if we're going to scale the evidence, we have to also have a scalable approach for the evaluation framework. And so I think to your curation point, we're not trying to curate data, we're trying to curate the evidence. And to curate the evidence, it probably can't be the idea that a select chosen elites are choosing what information could be shared, but rather that we do a broad scale education of how to interpret the information for yourself.
A lot of potential responses to that, but let's keep going here from the audience.
Hi, it's David Martin from FDA. My question's for Rory, and I don't work on GCP, so but my question is sort of broader. I thought I heard you say during your presentation that you felt like the role for observational evidence was only in the case of rare health outcomes where there's a large effect demonstrated. Of course, at FDA, we're routinely looking at both rare and common health outcomes in observational data. So one, I wanted to sort of check back in with you and make sure that I heard you correctly and that you really have this very, very sort of narrow view of where observational epi can potentially contribute. And then if that's the case, how do you envision closing that gap? Because we heard obviously from Rob earlier about how you have clinical recommendations and nobody's gotten out of the teens yet in a particular specialty society. So do you envision that whole gap being closed by reduced regulatory burdens and a blossoming of many, many more clinical trials? Or does that sort of imperative or that reality cause you to think there may be some middle ground and some need to expand the use of observational data beyond that very sort of restrictive sort of zone that I thought I heard from you?
Yeah, you did hear me correctly. So with respect to observational studies, I think in terms of being able to rely on the associations in terms of a causal relationship, that observational studies can be relied on for big effects on outcomes that would otherwise be rare. So a treatment that for a condition that is largely fatal, and then you give the treatment, you get people surviving. So survival was rare. I think that would be an example. But I mean, people referred to Bradford Hill. Bradford Hill was doing observational epidemiology on things like smoking. He was looking for big effects on what was a rare outcome, lung cancer. The epidemic of lung cancer was why he and Dole did those studies. So when I look at the kind of strategy that seems to be being espoused, I'm anxious that it's expedient. Now, I'm often a bit cautious about using certain words. I've used the word perverse once, and then I realized that it was seen to have a different meaning in North America. It's a little bit like being on an airplane where they say the plane is going to take off momentarily. In Britain, that means in a moment. For Americans, I think it means for a moment. Or maybe it's the other way around, but anyway. But so I did check expedient, and I don't want to claim that the strategy is immoral, the definition in, I think, a Merriman dictionary, but I do want to suggest it's improper for assessing moderate effects on common outcomes. There are other uses of observational studies, and I think around generalizability is where they can be used. So often the relative effects that one sees on different outcomes in randomized trials can be generalized to different populations where the rates of those outcomes may differ to determine what would be the net benefit and risk. So I think there are other purposes for observational studies in that context.
Right. So essentially you're saying the high internal validity world of the randomized clinical trial provides you with your feeling about causality, and then you don't have a problem with extension and additional inferences through real-world evidence that may build on that, like in subgroups and things like that. That's what I think I'm hearing from you.
To use it as the source of the absolute rates of particular outcomes against which one can apply the effect of the treatment from the randomized trials, to generalize in that circumstance. So, for example, if you had a treatment that reduced coronary events but increased hemorrhagic strokes, and in a place where hemorrhagic strokes were very uncommon, you might say, well, the benefit outweighs the risks. In another setting where hemorrhagic strokes, say China, are very common, then the risks may outweigh the benefits. So that would be the way that I think observational data could be used. But in terms of assessing the effects of treatment in terms of moderate effects on common outcomes, it may be the observational studies get the right answer. I'll give you an example. So statins, meta-analysis of the randomized trials suggested there was about a 10 to 15% increase in diabetes with statins that came about by looking at all of the randomized trials. There hadn't been any observational studies claiming that, but after that publication, 20 or 30 observational studies have been published to confirm it. What a waste of paper.
Mm-hmm. Right. No, thanks.
The strategy that you discussed, Rory, of assuming that the relative effect is relatively constant and then extrapolating. Just for FDA people, Frank Harrell, my old colleague who now works part-time at FDA, has been blogging wildly about this in favor of it. And I think it's pretty good reading and has a lot of the background material that you're referring to. Janet, do you want to comment on is Rory too rigid here about his? doctrine of randomized trials?
Well, there's also pragmatism. You have to don't forget what we do now is based on observational studies, or even worse, individual experience, okay? So you have to think about what you're starting with. My approach would be, let's get generating this evidence a lot easier and randomizing within the care system as much as we can, but we're never going to answer every single question. And so as we do these targeted therapy approvals, it has to do with your subgroup extrapolation. For example, I believe observational data, as the cystic fibrosis example, it may actually end up being perfect. You've established the treatment effect in some narrow group, and you want to bring that, broaden it out. I think you could use sort of Bayesian reasoning on some of that, mechanistic reasoning, all sorts of things. But I think in that zone Patrick showed, of that cloudy zone, that, I think it's going to be very hard for small effects, whether they're safety effects or efficacy effects, for us to say that just observational data nails it down. I think it's going to be really hard because there's so much, as you all know better than I, there's so much types of biases introduced there, and you can't correct for it because you don't really understand it.
Not that I would ever ask you a leading question, but so if you were just speaking about your current view within, I think you're in a group at CEDAR, CBER, CDRH. You're in many discussions which I had the privilege of participating in. So the sweet spot for you right now for converting real world data to real world evidence would be mostly the pragmatic randomized trial where you're using real world data.
No, I'm saying that's sort of the big issue that people want to address, okay? But I think there's so many other things you can learn from these real-world data. That's what I was talking about there. Your biomarkers, your behavior of your patient groups. You can do your trial simulations, because you don't want to rely upon 20 years ago knowledge of what happened to those people. You want to talk about contemporaneous outcomes, and you can look at those and estimate them based on observational information that you have. But I think that just the very fundamental issue, the causal inference issue, is going to be very difficult down at the low, whatever you call them, odds ratios.
Rory, you had a comment on it?
Well, there was a comment made yesterday about, we really should be increasing access to treatment, and I think the words used were, if it may possibly be beneficial. The reason why I'm concerned that is expedient is because it may well be harmful as well. There are a lot of examples where that is the case, where treatments have been used for, I gave the example of niacin being used by many people, but we've seen a lot of things that are done on the basis of, it seems like a good idea, antiarrhythmics after a heart attack, and they go on being done on the basis of case report or observational data, and they may possibly be beneficial, but they may also possibly be harmful, and I think we do need to bear that in mind.
John?
I think it's important that we, again, recognize that this isn't a replacement sort of piece. What we're really trying from our perspective in the industry is to say that the randomization is critical, and that causation is critical to understand and to lay the base on. But then as and I think you just described it, right, is the concept of understanding then more around that, around our patients, around the treatments, and that it's not a one ball here and one ball here. It's the idea that we know something from randomization that then we grow on our understanding through the use of different observational and other real world evidence methods that allow us to have a greater understanding of the environment, that's built around it. And I think the statins are a good example. I think anticoagulants are a good example. I think the use of Plavix and stenting was one in which we understood that there may be a relationship. Then we did randomized controlled trials. We proved it, and then the benefit just continued to grow through more knowledge, through real-world evidence. So I think it's really want to make it clear that it's about this expansion of understanding, not a replacement of one understanding for another.
Jeff Hurd, AstraZeneca Medical Affairs. My question is for Dr. Woodcock. Thank you for your time and your presentation today. Yesterday it was discussed that the FDA will issue draft framework by the end of next year for use of RWE in regulatory decision making, and then draft guidance by the end of 2021. So I have two questions. First, do you anticipate that the draft guidance will be robust enough that a manufacturer can take that guidance and with a reasonable degree of certainty conduct an RWE with appropriate methodology so that it will be acceptable with the FDA? And then second, what's the probability that the FDA will issue draft guidance prior to 2021 deadline? Thank you.
Well, I think we're all learning in this together, and this has not been the paradigm. So obviously, FDA, if we issue any draft guidance, we need to have the people on board within the different divisions. We can't issue something that then is not going to be accepted. So there's a cycle of training and discussion and mutual understanding that has to go on. So I can't ever speculate on the timing of issuing guidances because it's not under my control or any human's control, apparently. So, we have every intent. We're taking this very seriously.
Are you referring to political appointees as non-human?
Well, I'm referring to the fact that I don't think anybody really knows. And the greater interest in a guidance, apparently the more it's delayed, there's a direct correlation. So, but participating in all these efforts that we're doing, I think, are the most important thing, but also doing some demonstration projects, get people comfortable with how this might be done and so forth. But no, we're very sincere. CDRH has already issued final guidance, but you might argue it's at a high level. It's more of a principles than actually saying, oh yeah, we're going to accept this study.
Marcus Wilson with HealthCore. So just a great set of presentations from all the panelists. Rory, I particularly enjoyed your discussion about how we can improve the clinical trial infrastructure and the process for going through the clinical trials, and ultimately I think lower the cost of each individual trial. So here's the question / challenge for all of us. What can we expect in terms of the improved, let's assume that the spend on research stays the same, right? I mean, take the steps to improve the clinical trial process the way you've suggested. What's a reasonable or realistic expectation of the improved throughput now in terms of evidence development we could expect from those improvements? And the reason, here's the context for the question. Go back to Rob's point earlier in the day, and I very much subscribe to that thinking that only about 10-15% of our decisions are really powered by adequate evidence. So if we double, as an example, even our throughput through the traditional RCT process, our gap is still enormous. It's enormous. It's almost unimaginable how big that is. And so we would have to, 6 times increase the throughput by 6 times of clinical trials to actually close that gap. So there is a huge need for other types of solutions to that. So I think it's gone back to it, and John, you alluded to it as well in your comments on this. It's a blend of different types of designs to do this. And so I think that the expectations and the value of RCTs are tremendous, but I think the expectations and where we can get with just those alone, I think have to be realistic, and then think about how do we close that remaining gap. So that's my question / thought.
Well, I tried to allude to that in terms of cost, and I think that people are not ambitious enough. So let's take Fourier as a registration trial. So all trials don't need to be done to registration level, but let's take that as $1 billion. We've been running trials for 1/10 of that. Still now, complying with all the rules for registration. The heart protection study was 1/50th of that, done relatively recently, and again was used for approval. So I think that it's not one order of magnitude. I think it's 2 orders of magnitude cheaper. The ISIS trial that we did of acute myocardial infarction with aspirin and streptokinase was $1 million. I mean, albeit some time ago, but there are people like Ian Roberts doing trials like that now, the CRASH trials of head injury, that are answering really important questions, not just for developing countries about how to deal with trauma, that are demonstrating that treatments that were thought to work didn't work, actually were hazardous, and vice versa. So I think 2 orders of magnitude more data, more reliable data, more usable data, more generalizable data is perfectly reasonable. So I think you're being unambitious in your expectations.
Yeah, the reason I advocate for more of a hybrid model is that many of the questions, I mean, we often focus on the registration trials because that's the innovation side. Many of the questions Rob is talking about clinical practice guidelines have to do with what therapy should somebody take, okay? What path should they take given their own individual characteristics? And those studies are best done within the healthcare system itself, okay, with real people and real doctors treating them, because that's where you get the answers that are relevant to the healthcare system. But for the reasons that we've already talked about, many of them are best randomized. But beyond that, and that's going to call for then informed consent, okay? But beyond that, you can do almost every part of that within the healthcare system once you conduct that randomization. Most of them are going to be approved treatments or devices or whatever they're already out there. So answering those questions could be very inexpensive, and that's the idea behind the learning healthcare system, or whatever it's called. That's the whole idea behind it, is that you can generate that evidence pretty much effectively if we change how we do things and make randomization and research a part of healthcare. So I believe we could answer many of these unanswered questions quite efficiently if we were able to shift over to this sort of hybrid model.
And I think that randomization, and that's where Salford and some of the other experiments we're doing right now, the randomization does allow you then to continue to observe those patients over time and gain knowledge longitudinally, which we're doing quite a bit.
Well, Marcus, as you know, one of the dreams of the evolving PCORNet is that there would be a constellation of platforms, as Janet described, that would be essentially physically would be a consortium of patients with the disease, their families, doctors, insurers, and health systems that would say, for our problems, our most important questions that are unanswered, here's a common method, because really, the idea is you can substitute the treatment of choice into the decision algorithm and randomize, and then you get an answer. And that might be a way to achieve the kind of scale that Rory has talked about. But also built into that is a constant observation. And it is, I think, going to be increasingly a challenge for, let's just put reality aside and assume that, across the country, people banded together with diseases and their doctors, and you had these platforms. Then there would be a lot of decisions to be made about when you randomize and when you accept that the observation is good enough to proceed. But I would argue, as I'm looking inside of Google as an example, and what I've learned about Amazon and Facebook, that is actually the reality of what you're living in now for most of your life, to the extent that you're using the internet and media to get your information and make decisions about what you're going to buy and what you're going to pay for things and what your preferences are. That's actually the way it's being done. So why we should cordon off healthcare and say we're going to remain ignorant as a matter of practice when it's the most important thing. I think, Devin, you alluded to it, but at least in my construct of the world, it happened for a reason, which was the old days when everything was on paper and you had some very evil experiments that were done, that were not transparent. So it led to treating health data differently. I'm just arguing that where we are now in terms of the connectivity and the ubiquity of information, that we need to change the way that we think about it. It's an argument. So looks like people are ready for lunch. So can we spend just a couple of minutes on the two issues that I posed? And John and Patrick, if you could each, maybe John, you start off. What's your reaction to Patrick? Does it mean you should stop doing these stupid epidemiologic studies and just do all by all, or what's the answer?
Well, I think so the simple answer is probably not. The complex answer is I believe you have to do, you have to use the evidence in multiple different ways and triangulate from different angles to understand and refine the answer that you get so that you have more trust. And so as we've described, Rory described, right, there's a large trust level out of the randomization and the control. And then there's magnitude of trust that goes down. And so to me, on the single gives you a piece of information. The all in all gives you more information. But you have to decide what your question is and what's the best way then to answer that question.
So Patrick, what? I know that you're not saying we should throw out epidemiology, and in fact, just running the automated diagnostics is very helpful, but you still, if you don't understand the context in which the studies are done, et cetera, you've got a real problem. So how do you put it together? What's a logical extension of what you're finding?
Yeah, so certainly I'm not saying that we should do one analysis and that replaces the need, nor do I think we could even pre-specify the universe of questions we actually want to answer. What I am asserting is if we could apply a systematic process that consistently and reproducibly generates the same kind of evidence across a network, that we can remove the variability that is introduced by humans as part of the process and be left with the variability that's inherent to patient heterogeneity and health system bias and those issues. There's actually, I would say, there's going to be more work, not less work, for trained, qualified scientists to interpret the evidence that we're generating. So I don't think that we're replacing the epidemiologists. I think we're actually going to be empowering them, or at least I hope I can still have a job. But I do think part of the issue is that I would also favor the idea that we could have randomized trials if that was possible. But in the absence of trials, we're currently sitting in a current healthcare system where there's no evidence. And what I hear in the conversations is there's a risk that an observational study might not give us the right answer. Therefore, we should be very cautious about not doing anything. And Marcus brought up the point yesterday about trust. I think part of this is actually, instead of us not providing evidence, we should be thinking about how do we build systems that actually will engender the trust by putting the information out there. And I personally would rather be in an environment where we're putting out evidence and saying how much we trust it, even if how much we trust it isn't all that high. I'd rather be there than our current world, which is do a search from your employer and hope that the top blog that pops up is reliable information.
Yeah, before we move to the next topic, which will be just as much fun, you've sort of spawned the double-headed beast of Sentinel and OMOP. Right? The genesis of these was the funding from the FDA and the law that, I still, one of my learnings from working with you at the FDA is the way to get a good law is to convince Congress to write a law to tell you to do what you wanted to do in the first place.
Right.
It allows it to get done more effectively. So how do you reconcile Patrick's findings of all by all with what Sentinel is doing?
Well, I think they're very different, and I think they're taking sort of orthogonal approaches. And I think what we believe in science is that take orthogonal approaches, and if you have uncertainty, and then try to refine, bounces off each other, and then you learn more. So I'm thrilled by some of the diagrams Patrick showed, because it makes me understand more why we get all these signals that we can't verify over time. It's just so annoying, and everybody gets all excited about, and it causes a lot of uproar in the press and all this distractions. And so, and you know, there's some explanations for that. So I think, but I do think the approach that's being taken is a broader one, and the approach of Sentinel is taking a problem, so pragmatic, okay, what can we do now to answer this question, one question at a time? And they're both extremely worthwhile, and I think it's probably time to like bump them up against one another again and try to see, you know, what we know now at this point in time.
Yes.
Yeah, let me just pick up on that. You know, if you think about, and some of the discussion yesterday went to this point. If you think about how we're generating signals now with no real numerators and numerators that are influenced, Rob said, by newspapers and lawsuits. So that's what's giving us signals now. I mean, Brian Strom used to say, the plural of anecdote is not data. So even if we just think of this all by all as a complement, I'd like to say substitute, but at least as a complement to what we're doing now, you know, we have a much more reliable way of generating signals than what we're doing now. And, you know, it's not quite at the push of a button, but it's got to be orders of magnitude better than the spontaneous reports.
Spontaneous reports, we do find a lot of things. We put them in the label. Whether or not they're all true is unknown. Okay, they're very much like case reports. I mean, it has the same, that's what informs clinical practice, and often in the safety side, what informs the FDA label is these spontaneous reports, where we try to use totality of the evidence. We got to do better than that, I agree, because at the end of the day, we're missing a lot, and then there are a lot that aren't actually the case, okay? But we got to figure out how to do that.
So when we've had a lot of discussion internally at J&J about this, and we're planning to go through the exercise of let's look at specific label changes. We've already done some of this. None of it comes from spontaneous reports of non-serious events, right? But if you imagine, Stevens-Johnson is a great example of something that where spontaneous reports really can be useful, but if we had a truly interconnected world of electronic health records, you know, a case of Stevens-Johnson is not going to get missed, and it's not going to be misdiagnosed any more than it would for a spontaneous report. So, you know, something comes up in a health system somewhere, it gets flagged, and, you know, it gets reported automatically to FDA. I mean, there is a future here that maybe we're not quite ready for now, but.
Well, can I just say one more thing about that particular thing? Well, to what you talked about, the reports and all the different problems from trials. You know, FDA has tried to change this over time in how we look at this, and we've gotten a great deal of opposition from other parts of the world. So I think we all agree that right now our methods, you know, need improvement, and we do need harmonization, though it isn't good to have different methods going on in different parts of the world. Everyone agrees that looking at randomized safety data is more convincing for all the reasons we've been discussing than looking at spontaneous reports and so forth. But we don't have enough of the randomized safety data, and during the trials we don't use a rational way of looking at it. No argument there. We proposed a more rational way, and it's more or less been rejected. So there's bottom line, a lot of room for improvement here. A lot of things we do, I think, can improve the situation.
David, go ahead, then I have a comment on that.
Sure. I was just going to add a little quick context to kind of this whole discussion. I don't think that Patrick's approach and some of the things that have been done in Sentinel are completely separate. But as Janet said, there were orthogonal approaches. And let me just make this very concrete for you. When I led an epidemiology division at FDA, I was awash in a sea of hypotheses, a sea of case reports coming out of the literature from well-respected medical institutions, endless MedWatch reports. I also had vaccines, so I had VAERS reports and everything that goes with that. And so when we first had the chance to implement and saw funding for Sentinel, our first desire, or sort of our first need, was not to acquire more hypotheses. It was to actually attempt to deal with those hypotheses, refine them, evaluate them, and make a regulatory decision. And of course, I'm taking you back to 2009 timeframe, just to give you a sense of like the genesis of the program. And it doesn't mean there was anything wrong with hypothesis generation. It was more like we kind of put that off on the side on our to-do list and said, okay, let's focus on this. And the other thing that we had was, even internally within the agency and of course externally in the broader community, we had a lot of people saying, well, there are advantages to using, for instance, claims data like we would see in the Odyssey output. And one of those is obviously you have person time under observation. You're reasonably sure about the medically attended events, that they've actually occurred, all those great benefits. But we had a lot of other people, particularly, say a rheumatologist in the appropriate division in OND, who might say, I don't get enough out of this claims data, I need to know more. So we had to spend a lot of time also exploring the relationship of the claims data to the underlying medical records, looking at sensitivity, specificity, positive predictive value. So what I would say is, we sort of had this this sort of natural evolution because we couldn't divorce what we were doing from the daily public health mission of the FDA. It does so happen that we did launch something called tree temporal scanning, which is an alternative approach to trying to do sort of like an all-by-all, So there are some areas of convergence, and I think that over time it'll be really interesting, for Odyssey and Sentinel and FDA to work together going forward. And the last thing I'll mention is as Janet was sort of saying, that the individual case report will probably never go away, completely. The only other vignette I'll share with you was when we launched pandemic flu vaccine, there was no data from the health systems, because there's data lags, and to aggregate at like a national level. Of course, that's back in like 2009 timeframe. But you could have maybe aggregated solely off of EHRs, but the claim systems, there were data lags. And so we were several weeks into the flu pandemic, and essentially you could say flying blind except for MedWatch and VAERS. So at the end of the day, it was pretty funny because there would be like conference calls coming down from HHS down to my division, sort of like, assistant secretary wants to know how many VAERS reports came in today, for this, that, or the other, and it would be like, yes, here you go, this is, and then internationally we were sharing these reports, we're working with. So the bottom line is like, I don't think the case report will die, but we do definitely see the merits of what you're talking about. We too want to do population-based signal detection, and we want to do more broad evaluations. I don't want to also call this just signal detection. There's another angle to this, but anyway, I just want to let you know there's a lot of some of these different ways that things were done have to do with just the differing mandates and the need to meet that public health mission.
Well, we got 5 minutes left, so I just want to make one comment about that. It comes home to roost for me right now, and I hope we can do something about the label, the adverse event side effect issue. 3.5 billion searches a day on Google, 20% are health related. Out of those, one of the most common questions is this experience I'm having a side effect of a drug? And of course, all you can get right now is a list of a bunch of stuff. As Greg said, you can have constipation and diarrhea at the same time, which is a miracle caused by a drug. But most of it is junk. and yet there's a desperate need of people all around the world to get useful information. So I hope we can converge these things. I do want to, one minute, Rory. Are you saying we should totally get rid of GCP and have no guidance for the hundreds of thousands of people conducting clinical research studies on how to do it?
I think the nice thing about coming from Britain to North America in this area is the FDA has been the one who's been leading the charge against actually ICH and GCP with quality by design, central statistical monitoring, more appropriate safety reporting. But I think the analogy I would see is that Dr. Frankenstein created a monster, and the way to kill the monster is stake through the heart. And that what we need are guidance for the 21st century, which does talk about using all of the electronic data record systems in an appropriate way, that does involve randomization, as Janet's saying, in a whole series of areas. And I think that while we've still got this 19th century set of guidance, it's going to be very difficult to do that. So I would pull the plug on it. I think the people who fund it are really the regulators, and FDA could take a lead in pulling the plug. And that what we need is to start again. We need to have 21st century guidance. It needs to involve the regulators and industry for registration trials. But it also needs to involve public and patients and academic experts in clinical trials for the vast majority of trials that are not regulated. And also the funders, not just the industry funders, but the government funders and the charity funders. Gates is trying to do good in developing countries, and he's, with respect to clinical trials, doing harm. And I don't think that that's the intention. I think that they need to engage in ensuring that charity funding, government funding is being used appropriately in randomized trials. So, I would kill it.
Yeah. You're going to put the stake through the heart?
Well, let me just say a few things about this. Now, the FDA guidance that adopts ICH goes through a transparent public process. It's just nobody was paying any attention in the 90s, okay, to good clinical practice. So we do sort of notice, we issue a draft, we invite public comment, we often have workshops on different guidances. So it is transparent, at least in the United States, because that's what we have to do, even for ICH guidances. Second, regulation is usually, and it's aimed at the bottom 1%. That's the problem with regulation, okay? Because you wouldn't believe what some people will do. And they do it. And so we have to have rules that do protect people, because there are what I call bottom feeders out there, and those people, will do things that will astonish anyone. And some of those, are developers or whatever are doing FDA-regulated trials. So we got to have some kind of structure to guard against that and protect people, because those kind of abuses give the whole enterprise a terrible name and cause terrible harm, okay, and makes people not want to volunteer for trials, and it can be even generational sometimes that distrust is passed on. So I don't think we can totally throw out everything, but I do believe in this century we need more flexible understanding of quality, and that is a natural evolution of sort of the quality revolution, which has moved from quality control, which was a very mid-20th century concept, all right, to quality by design or quality management, which is really where we need to go. And we have been trying to go there with the clinical trial enterprise. Quality by design is part of that, but also then the idea of constant monitoring and not the kind of monitoring you were talking about, but constant oversight and course correction of whatever you're doing to continue to improve the quality of your efforts. So we're open to that, but I think you can't just stake in the heart and have no rules for some period and then come out with something else, we're going to have to propose, and we have been doing that through city, through ICH, through other efforts to try and modernize the approach.
Would you advise that people just work through the current organizations, or how amenable are you to more aggressive approaches like sending in suggested guidances and things like that?
I think we're very amenable. The current rules, we also have for regulated industry, they can come in and propose a protocol, okay, that doesn't conform, and they can say how they are doing that, and then we can accept it, and they can go ahead and do it. So it isn't a straitjacket right now, okay? However, there are other cultural problems. There's a huge cultural issue in industry in the CROs, right? And the regulatory departments and some of the other departments have their own power base of knowledge about how you have to comply or follow the rules, okay? And so there's a great deal of conservatism. So I think any attempts from the academic sector of proposing changes probably would be welcome and be kind of a breath of fresh air, because probably the regulated industry isn't in a position to propose most of those.
Right, so we're out of time. This has really been a fun panel for me. I hope other people have enjoyed it. It's really critical topics. So I'll turn it back over to the chair here to close the session.
So we have reached, I guess I would say, not necessarily our adjournment, but our intermission. This is, as all of you know, is the first of a series of 3 workshops. So, briefly as we get ready for our intermission, I would like to say a few thank yous. As we said at the beginning, I do certainly want to thank the FDA's Office of the Commissioner, which has sponsored this ongoing activity, to acknowledge the National Academies Drug Forum, which is the host of this workshop series. Members of the Planning Committee, many of whom you've heard from, who actually put in quite a bit of work over the last few months on many conference calls putting this together. I do want to thank Amanda Wagner-G, who's in the back, and her colleagues at the National Academies who organized this. What comes next? The slides from the presentations that you've seen over the last couple days will be posted on the National Academies website within the next week or 2. The National Academy staff will prepare a summary of this meeting, which is not recommendations or policy, but really just an attempt to summarize what was said, so that there will be some summary record of that. And that will be made available to anyone in the public before, I don't know what the time frame is, probably within the next few weeks to a couple of months. Our second workshop we've begun to think about, and actually would welcome suggestions. The current thinking about that is it's time to move from generalities to specifics. If our answer to the question of what's the right way to do research is it depends, we need to work some examples. So what we'd like to do is actually publicly work some illustrative examples, and we're thinking about those. And likely those would include examples across a range of the challenges we've talked about. Examples ranging from how do we speed a breakthrough treatment actually coming to market? How do we identify and verify important new indications for existing treatments? How do we assess long-term outcomes of treatments that are already licensed, especially